Good day, everyone. I'm Dr. John Ward. I'm the director of the Coalition for Global Hepatitis Elimination at the Task Force for Global Health here in Atlanta, Georgia, in the United States. It's my pleasure to introduce you to a three-part webinar series where we'll be examining the implications for hepatitis C care for pregnant women and the care for their newborns. This is a three-part series. The second and third part will be held in January, March of next year, as you can see here on the slide. If you're registered for this webinar, you'll be notified of those as the agenda for those are developed in the coming weeks. And I want to thank Gilead Sciences for the resources to put this webinar series together and present it to you starting today. Next slide, please. Tell you a little bit about the coalition here at the Task Force for Global Health. The task force was started about 40 years ago by former CDC directors to conduct a variety of global health initiatives, including a variety of disease elimination initiatives. And that's why I moved over from my position at the Division of Viral Hepatitis at CDC to start the Coalition for Global Hepatitis Elimination, to build on that experience and to bring together these different partners with the resources and the expertise to put in place national and subnational programs that can advance progress toward goals for hepatitis B and hepatitis C elimination. And we do that in three pillars of work. Building a community of practice, which this webinar is an example of, to bring people together to share lessons learned and build expertise and capacity around the different components of effective hepatitis elimination programs, as represented on the figure on the right. We bring together credible evidence. Again, this webinar is part of that, with including country dashboards for over 190 countries, systematic reviews on a variety of different topics, including care for hepatitis C for pregnant women. And then we do a variety of sort of global awareness raising, most recently at the United Nations General Assembly, convening a side event leading to the formation of the first UN group of friends of member states coming together, expressing commitment to working together to advance progress toward hepatitis elimination. And I encourage you to go to our website at globalhep.org, sign up for our monthly newsletter, where you can get regular information about what's happening in the area of hepatitis elimination, as well as sign up for our Twitter feed, as we'll give you even more frequent information. And as part of that, all of the materials from this webinar will be available on that website. This video in full, the video of the different speakers and panelists, slide sets, and a overarching summary document so that the highlights from the webinar can be revealed. I think you'll see here in just a moment, we have a blue chip set of speakers and panelists to begin to share information and perspectives about hepatitis C care for pregnant women and for their infants. So it's my pleasure at this time to turn over to my colleague, Dr. Neil Gupta, the Chief Technical Officer for the Coalition, to start the program today. Neil?
Thank you so much, John, and hello, everyone. Thank you for joining today. We're thrilled to kick off this webinar series with our first session today. As John mentioned, it'll be a three-part series, and we hope that as you're registered for the first, you'll be able to follow through with the second and third sessions as they come along. Today, we'll be focusing on the challenges to hepatitis C linkage and treatment in pregnancy. Next slide, please. So just as by way of background, the way that the Coalition for Global Hepatitis Elimination came to initiate the TiP-HepC project was really in recognition that over 20% of Hep C infections globally are now in women of reproductive age, as we'll hear more about from Dr. Collins and the epidemiology of hepatitis C in pregnancy. Now that hepatitis C screening in pregnancy is recommended in the US and has been increasing globally, we're finding ourselves in a situation where we have concrete testing recommendations without clear treatment guidance or recommendations for individuals diagnosed with hepatitis C in pregnancy. We all know, and I think most of us on this call recognize, that postpartum treatment and infant follow-up has been extremely challenging to date. And we'll hear more about that from Dr. Krantz. And that we also have very limited safety data regarding hepatitis C treatment during pregnancy, which remains at provider discretion. So our options are not great once we roll out screening and have individuals screening hepatitis C positive during the pregnancy period. Next slide, please. So in recognition of those background aspects, we launched the TiP-HepC project with 3 objectives. The first was to compile evidence, initiatives, and policies related to hepatitis C testing and treatment in pregnancy globally. And you'll see at the website there below, and we'll drop it in the chat here, we have an evidence base online that has been assembled and accessible to the public. Secondly, and a major part of our work has been to develop and launch a global clinical case registry to document hepatitis C treatment exposures as well as their outcomes in pregnancy for both the mother and infant. And then finally, which we're happy to kick off today, is a community of practice, as well as an advocacy coalition to improve linkage to hepatitis C care and treatment following diagnosis in pregnancy. Next slide, please. So a quick word on the case registry, the TiP-HepC case registry, now open for business. The objective of this registry is really to enhance the evidence base to inform patient-provider decision-making on hepatitis C in pregnancy. Testing positive, what do we do next? And we really launched this registry with the aim to provide more evidence, more guidance on the treatment options that are available to both patient and provider. This registry works by voluntary case submission on documented hepatitis C treatment exposures during pregnancy, as well as the outcomes of pregnancy and birth. So it's voluntary, and it really relies on your case submissions. So encouraging you all here to submit when and possible and disseminate amongst your networks. There's a QR code here, as well as a website that's been dropped in the chat. The registry was launched just 5 months ago and has been disseminated by major professional societies, as well as been in the literature here, as you can see with a commentary in the Lancet Gastro. And it's also included on the FDA website of Pregnancy Exposure Registry. Next slide, please. So without further ado, we'll dive into today's agenda. As John mentioned, we have a great lineup of speakers. We'll hear first from Dr. Collins on the epidemiology and vertical transmission of hepatitis C in pregnancy. Then from Dr. Krantz on the care cascade for women diagnosed in pregnancy. We'll hear from a wonderful patient, Danielle Baker, who has joined us today about her experience with hepatitis C in pregnancy. And then finally, we'll hear from Dr. Saeed Hamid from Pakistan on women's preferences in a recent survey. And then we'll kick over to a roundtable of professional society representatives that are joining us here today from a diversity of professional societies, all very engaged and involved with TiP-HepC. So with that, we'll turn over to our first speaker. Next slide, please. Oh, apologies. Just one housekeeping notes. As John mentioned, you could submit questions in the question and answer. Afterwards, we'll post all the materials as well as the recording on our website, globalhelp.org. And please do sign up for the coalition newsletter. We'll also end with a quick poll. So look for a poll to pop up towards the end of the meeting. Hope you can all stay with us for that. So on to our first speaker, Dr. Indira Jeannie Collins. Thank you for joining us. She's the Principal Research Associate at the MRC Clinical Trials Unit at University College London in the UK. Dr. Collins, over to you. Thank you so much. Dr. Collins, still on mute, just to see how that.
Thank you. Can you confirm that you can see my slide?
I can confirm, and if you can switch to the slide view, might make it a little bit larger. Great.
Okay. Like this and, okay, is that still working fine?
Looks great. Thank you.
Great. Thank you. Thanks very much for the opportunity to present here. So I'll just get straight on. So this is the outline of my talk today. I will first be giving an overview and update on the epidemiology of hepatitis C in women of reproductive age, and then an update on some of the evidence we have around the effect of hepatitis C infection in pregnancy in terms of adverse maternal and infant outcomes, and estimates around the risk of vertical transmission, and updates around hepatitis C screening policies for pregnant women attending antenatal care. So first, I'd like to just step back slightly and review the context of this in the global goal for the elimination of hepatitis C by 2030 and where we are in terms of this goal. So the goal is to have a 90% reduction in the number of people living with chronic hepatitis C by 2030 compared to the baseline estimate in 2015. To achieve this goal, we would have to diagnose over 90% of all those people living with chronic hepatitis C and to treat at least 80% of this population. Now, this snapshot is from a recent paper from the Polaris Modeling Group, and they've estimated our baseline estimate from the start of 2015 is that we have 63.6 million people living with chronic hepatitis globally. Looking at what's happened between 2015 and 2019, we can see that there are an estimated 7.5 million new chronic infections during the 5-year period, and 8.7 million people have already been treated and cured of hepatitis, and 5.5 million people have since died in this period from all causes. So our latest estimate on the global prevalence is at 56.8 million people with viremic infection as of the start of 2020. Now, this represents a 10.7% reduction in the total number with the burden of disease from our baseline of 2015. So we clearly have a long way to go to reach the target of a 90% reduction by 2030. Now, the current estimate of the global prevalence is at 0.7% globally, but wide variations across country ranging from 0.1% to highs of 4.7%. Now, the HIV cascade overall for 2020 was that an estimated 23% of all those chronic infections have been diagnosed and 5% only treated in that year. So the WHO has since issued a guidance this year to accelerate the uptake or access to hepatitis C diagnosis and treatment, and recommending a test and treat for all adults and children now from age 3 and above, but still excludes treatment of pregnant and breastfeeding women due to a lack of safety and efficacy data. And while we hope that there will be more data and large trials looking at this question going forward, I think there's increasing recognition that there's a need to look at more closely opportunities to test and treat women of childbearing age, as they could be a key population which can help us reach our global goal for elimination. So this is the first study. The same modeling group has issued the first paper issuing the estimates around the global prevalence of viremic hepatitis C in women of childbearing age, who are defined as those aged 15 to 49, who account for nearly 1/4 of the world's population. Now, they estimated as of 2019 the prevalence to be around 0.78%. This equates to 15 million women of childbearing age globally with chronic infection, and accounts for about 1/4 of the global burden of hepatitis C. Half of the women with viremic infections reside in 4 countries: China, Pakistan, India, and Russia. While China and India have relatively low prevalence, they have such large populations. Countries with the highest prevalence of hepatitis C, defined as using the cutoff of over 4% among women of childbearing age, are those listed here: Mongolia, Burundi, Gabon, Uzbekistan, and Pakistan and Russia. There are currently no recommendations for routine hepatitis C screening among women of childbearing age. And I'll go into more detail about how there are relatively few countries implementing universal screening of pregnant women in antenatal care. There have been some studies looking at the prevalence of hepatitis C among pregnant women, but most of these are seroprevalence studies looking at antibody status. And this has ranged widely from less than 0.1% to 7%. There's an important note of the differences in risk factors for hepatitis C status in pregnancy according to different countries and their different epidemics. In countries with concentrated epidemics, the hepatitis C status is often associated with past or current injected drug use. In countries with more generalized epidemics, the risk factors are much more varied, including history of blood transfusion or having medical surgery, hospitalization, or having family members with hepatitis C. So while it's clear that there's potential great opportunity to improve the testing and treatment of women at childbearing age, it's also important to note that there are an estimated 3.2 million children with chronic hepatitis C globally. And vertical transmission from mother to child is the most common route of acquisition in children, accounting for about 60%. So there's real opportunity for double dividend in that improving testing and treatment of women of child reproductive age, we can also potentially avert some of these future pediatric infections. Furthermore, it's important to note that HCV infection in pregnancy is also associated with adverse maternal and infant outcomes. We've had large meta-analyses, including data on over 4 million pregnant women that have reported associations of hepatitis C being associated with increased risk of preterm birth, low birth weight, intrauterine growth restriction. But many of the data and the studies which contributed to these large meta-analyses did not have complete data or were able to fully adjust it for important confounders such as tobacco, alcohol, or drug use during pregnancy. However, having said that, there was a recent very nice paper from the US looking at national inpatient routine care data of over 28 million pregnancy-related admissions, where those key confounders were fully documented and adjusted for, and they were able to show a clear association between HIV infection status in pregnancy being associated with a higher risk of preterm birth, adjusted odds ratio showing a 12% increased risk of this preterm birth, 27% increased risk of intrauterine growth disturbance, and also increased cost of hospital stays. But most of these studies have largely come from high-income countries, and there's very limited data of pregnant women in low and middle-income countries where their characteristics and risk factors may be quite different. So there's a clear need for more data from those regions. In terms of vertical transmission, there remains gaps in our understanding around the timing and the mechanisms for this. One of the large studies to date has been from quite an old meta-analysis published in 2014, which estimates the risk of transmission to be around 5.8% among women with mono-Hep C co-infection, and the risk to almost double in women with co-infection with HIV, although most of those women were not receiving suppressive antiretroviral therapy for their HIV. And more recent studies have shown if the pregnant mom was fully suppressed for their HIV virus, then the excess risk is somewhat reduced. A more recent study has been looking at individual patient data meta-analysis, including data from 3 large European cohorts, which again assess the risk of vertical transmission, but also accounting for potential for early clearance in the infant. And their estimate was slightly higher at 7.2% in the mono-infected population. But all of these studies have shown that hepatitis C viral load is the main risk factor associated with transmission. Maternal genotype, mode of delivery, and breastfeeding were not considered as risk factors. However, it is important to note that many of these estimates are based on really quite old data, and often including children with incomplete follow-up, which was mentioned earlier. And there's a clear need for better, more recent and improved data on this. In terms of policies around hepatitis C screening in antenatal clinics, WHO still recommends risk-based screening. There has been a move towards recommendations for universal screening of all pregnant women attending antenatal care from the bodies shown here. However, In a recent global review of national strategies around hepatitis C screening of pregnant women, including a review of data on 122 countries, we found that 74% of these countries had no specific recommendations focused on pregnant women. Of the 32 countries with recommendations, 19 recommended universal screening and 13 recommending risk-based screening. Although in low middle income countries, despite these recommendations, some women may have to face user fees and therefore may not be able to uptake all of the screenings offered. Having said that, there are increasing data to show the cost effectiveness of universal screening of pregnant women, despite assumptions on relatively low retention and uptake of treatment postpartum. So this could be even more effective if we were able to improve the retention postpartum. So in summary, I think we'd like to advocate that the elimination of hepatitis C has to include everyone, including pregnant women, breastfeeding women, and their infants, and their largest burden is in low and middle income countries. Hepatitis C, there is increasing evidence of this association with adverse outcomes for both mother and infant, and there's a clear risk of vertical transmission. Universal screening and antenatal care is clearly a unique opportunity to identify the women in need of closer monitoring in pregnancy, to refer for treatment, and also to ensure follow-up of the exposed infants. We're also very interested in the potential of treatment during pregnancy, which has clear potential for additional benefits still. And I'd like to flag a future talk by a colleague, Elizabeth Chappell, who'll be talking about a future trial aiming to look at this in the future at the next webinar. And we'd also like to advocate the need for a hepatitis C cascade of care data specific to pregnant women and their infants, as we have done for many years in the HIV field, to help us to better monitor the progress in this specific population. And just like to thank my colleagues who contributed to the slides. Thank you.
Thank you so much, Dr. Collins. And again, if participants have any questions, please do send along in the chat, and I'll ask Dr. Collins to keep an eye on the chat as well, and can answer questions as we go along with the subsequent presentations. So with that, I'd like to invite Dr. Liz Krantz. Dr. Krantz is an associate professor of obstetrics and gynecology and reproductive medicine at the University of Pittsburgh, and the director of the Pregnancy and Women's Recovery Center at the Women's Hospital, and has been actively researching and publishing in this area for quite a long time. So Dr. Krantz, over to you, and thank you so much for joining us today.
Absolutely, I am thrilled to be here. Can you just confirm that you guys can see my screen okay?
Yes, I can see it, and now it's in slide presenter, which is great. Thank you.
Yeah, you do have the right, because I have two screens. Okay. All right, so I'm just excited to talk to everyone today about this incredibly important issue. So when we refer to concepts like the hepatitis C care cascade, what are we really talking about? So in pregnancy, or the perinatal period, that starts with screening. And in the United States, we have now, fortunately, gone to a universal screening for hepatitis C approach, which is relatively recent. So all pregnant individuals, and especially those with substance or opioid use disorder, should be screened for hepatitis C. And that really is a hepatitis C antibody with a reflex to an RNA to understand evidence of chronic infection. However, there are currently no FDA-approved medications for the treatment of chronic hep C in pregnancy, which has been mentioned already in this webinar, which creates barriers to the receipt of treatment. So what happens is we screen and evaluate patients for hepatitis during the perinatal period, which is a time of really intense healthcare engagement due to a variety of reasons, including expanded healthcare insurance coverage. But we have to refer them to treatment in the postpartum period. And so what happens is you have this inherent discordance between the diagnostic process and the receipt of treatment, which creates many barriers that I'm going to discuss and illustrate it through some of the research that we have done with my colleagues, Dr. Marian Jarlinski and Dr. Catherine Chappell. So we wanted to look at the population level to see how this linkage of care, or this care cascade between screening, evaluation, and treatment, how's that been going with the current landscape of treatment. So we looked at a multi-state Medicaid, Data Research Network, which was something put together by my colleagues here at the University of Pittsburgh to, again, try to understand what happens in this care cascade between the diagnostic process and the receipt of treatment. So the research network is composed of Medicaid administrative healthcare data, which is our, in the United States, our publicly funded insurance program that is delivered through the states. And we combined healthcare data from 6 states in the United States. That's Delaware, Kentucky, North Carolina, Pennsylvania, and West Virginia. And what's important about some of these states is, especially Kentucky, Pennsylvania, and West Virginia, there's a very high prevalence of substance use related disorders within this particular geographic region in the US. And so because we know hepatitis C is now predominantly acquired and transferred through injection or intravenous drug use, having a high prevalence of this particular population was key to our analysis. So we looked exclusively at the population of individuals who had opioid use disorder, again, one of the highest risk factors for the acquisition of hepatitis C. So this was a subset of the general population, again, only substance using individuals and opioid use disorder. They had to have a live or stillbirth delivery after 24 weeks gestation. And the time period we looked at was between 2016 and 2019. So in order to be able to capture if they had been screened or evaluated in pregnancy, part of our inclusion criteria is they had to be enrolled in Medicaid for at least 6 months during pregnancy so that we had time to observe the ability to be screened for hepatitis. So, and we followed women through 60 days after delivery. So all women, when they received Medicaid eligibility or Medicaid insurance due to their pregnancy, are mandated under federal law to be followed or to be insured for 60 days after delivery. So that's a minimum requirement for the entire population that we evaluated. However, a subgroup of women remain continuously enrolled in Medicaid for 6 months after delivery. So we were able to look at a subset of the total population of our sample to extend beyond that 60-day period to 6 months to see if we could pick up more incidences of treatment in the postpartum period. And again, this is a very US centric, but in the United States, this occurred before our more recent 1-year postpartum expansion of Medicaid delivery. The data is from you could receive Medicaid after the 60 days if you had income eligibility for Medicaid related on your household income. So that's how some of these individuals were able to maintain Medicaid coverage for 6 months. And that would be in states that had ACA era Medicaid expansion, which were all the 6 states with the exception, or 5 states with the exception of North Carolina. And like I said, this was postpartum coverage expansions, which is really recent to this particular year. So what was our final analytic? We had over 23,000 patients that we were able to look at who had opioid use disorder. And then 83% of those were actually remained continuously enrolled for 6 months after delivery. So a very large sample size and truly the ability to look at this on the population level. All right. So it's a little bit about administrative data here, just to help to put this in context. So how do we define hepatitis C testing? So that was the presence of any procedure codes in the healthcare administrative data for an antibody or RNA testing between the estimated date of conception and the date of delivery. Again, minimum of 6 months enrollment, but we tried to look through the entire pregnancy period. And if they had evidence of these tests in the data, we counted them as having been quote unquote tested during pregnancy. Similarly, we looked from a diagnostic perspective, whether there was presence of the diagnosis or evidence of the disease, and this was a yes/no binary variable. So that would include any ICD-10 diagnosis code for chronic or acute hepatitis C infection, again, between the pregnancy period. And importantly, so that one of the primary limitations of administrative data is, which is really the only way to look at the population level, is we don't have lab results. So we have codes that indicate that testing occurred. So we had to go to diagnosis codes to make the assumption about whether or not somebody had the infection versus the results of the laboratory test. So there's some inherent limitations in that approach, but that is what we have, but it's important to mention that. And we tried to look at the timing of these testing codes and the diagnostic codes to try to, again, really create a longitudinal relationship between the testing process and the diagnostic process, because clearly several patients may come into the care cascade already having the diagnosis prior to pregnancy, although it's extremely common to get that initial diagnosis due to that healthcare engagement in the pregnancy period. So postpartum follow-up, we looked at a follow-up visit after delivery, which was also a binary measure of it happened or it didn't. And that was either a visit with somebody whose subspecialty was related to hepatitis, like hepatology, infectious disease, or gastroenterology, or we counted that as a visit with a primary care provider where hepatitis C was a primary diagnosis code recorded for the visit. So that's how we defined whether or not patients followed up for a hepatitis C specific reason versus a variety of other reasons that clearly can occur in the postpartum period. And then finally, postpartum treatment receipt. So not only did they receive a visit, but did they initiate treatment in that postpartum period? So this is where we looked at pharmacy data to see if there were any outpatient prescription fills during either the 60-day to 6-month window of any medication that could be used to treat hepatitis C, all the way for the interferon regimens, all the way to the DDA. So this was anything that could have been used to treat chronic infection. Then clearly we had adjustment in the analysis for a variety of patient level variables that could be associated with either substance use or opioid use disorder or hepatitis C infection. So what did this population look like? I think this is important to kind of review the demographics of our sample. So the vast majority of individuals were white, and then we had 7% Black and 2% Hispanic. 55% of individuals were taking a medication for opioid use disorder during pregnancy. 60% had a co-occurring non-OUD substance use disorder, like a stimulant use disorder or an alcohol use disorder. 5% had cirrhosis or liver disease, again, based on diagnostic coding criteria. And 5% had an infectious sequela of injection drug use versus diagnostic criteria. And that would be something like endocarditis or sepsis. So here is the care cascade. So this was a multi-state analysis. So our data was presented by individual states to look at significant between state variability, but then we also had an aggregate overall prevalence estimate. And I just wanted to just start with these raw prevalences to start the discussion. So if you orient yourself to the left side of the screen, this is the percent of patients who received a hepatitis C test. Again, this was an antibody and RNA test during pregnancy. And if you look from A through L, which are the 6 states we evaluated, there is some variability, so that the highest prevalent states would have 79% all the way down to 60%. But on aggregate, you have about 70% of women who had a known opioid use disorder diagnosis in pregnancy were screened and evaluated for hepatitis. So this is prior to universal screening recommendations during this window that we evaluated, but they had a clear risk factor for the need for screening and treatment, which was the recommendations prior to universal recommendations. So all of these women should have been screened and evaluated. So you see a 30% miss rate here in just screening and evaluation. And then if you look at the diagnosis rate, the next column, about 32% of these had evidence of an HCV diagnosis in the data. And this is just interesting. So we looked at how many had a diagnosis before the test, looking at that timing again. So how many patients presumably were coming into pregnancy with a known diagnosis, about 6.2%. And what was the relationship to how many women were getting the diagnosis after the test in the administrative data, and about 20%. So here that's just highlighting again the importance of the screening and evaluation in pregnancy and how many more women are getting newly identified and newly diagnosed in this really critical, important window. And then if you look at this second kind of larger column, 60 days postpartum here, you see our follow-up visit rates about 10%. And it was a relatively, we counted any kind of follow-up visit that could have had anything to do with hepatitis, and only 10% of individuals followed up for a visit. And then here, let's look at the medication treatment uptake, which was less than 1%. Now, when that's 60 days postpartum, so that's universally what everyone is mandated by federal law in the United States. If you stretch that out to 6 months postpartum, you do see an uptick here in the receipt of visits for hepatitis-related diagnoses, but it continues to be abysmal initiation of treatment medication around 2.6%. And this is just kind of a more visual representation of the care cascade. So on the left-hand double bar, so the lighter shade is the 60 days, and then the darker shade is the 6 months. And the left two bars are testing, predicted probabilities in adjusted analyses. The middle bars are diagnosis, predicted probabilities, and then follow-up. And here, because the rates of treatment with medication were so incredibly low, we combined the receipt of medication or any follow-up visit into the same outcome variable, because rates were incredibly low, and then differential between the 60 days and 6 months. And if you look across states, the only place that we're starting to see a difference between the 60 days and 6 months intuitively is between these follow-up periods. The more follow-up time we had, we did see a statistically significant uptake in the receipt of visits, although the overall prevalence or predicted probability continues to remain incredibly low. When you aggregate all of those together, this is for all of the states together, again, you see these same patterns, and then the only significant difference here on the right-hand side between follow-up in the different two time periods that we looked at. We're not doing a good job at all. And what are some, and this is just, there are multiple, but just to throw out a few gaps and barriers to consider as we go along this entire process. At the provider level, how do we communicate the need for Hep C screening and educate patients regarding risk factors for infection? So how do we communicate the need for this process, both amongst providers and to patients? And once diagnosed, how do we communicate the need to treat Hep C and educate patients regarding sequelae from untreated diseases? And how do we link patients to treatment? So is it a passive recommendation, like you need to go do this, versus an active coordination of care where we are truly facilitating the linkage to care and the uptake of treatment? And how do we create a provider workforce that is more comfortable with screening, evaluation, and providing Hep C treatment? And from a patient's perspective, how do we really how do patients prioritize Hep C infection when they may be in an unstable recovery process and they have a lot of competing demands? Where does the treatment of Hep C fall along those huge list of other things that are going on in their life? And what motivates patients to pursue treatment when they are largely asymptomatic at the time of an initial diagnosis? Like many chronic disorders, initially it may not matter to you, or you may not feel different that you have hepatitis. And how do we address that issue? And on a system level, clearly, how do we integrate Hep C treatment into obstetric primary care and community settings? So again, this is not an exhaustive list by any means, but just some of the things we thought about after looking at for the data. But now I want to switch over to talking and hearing from Danielle Baker, who I would not call you a patient, Danielle. You are part of our family. We have known Danielle for several years and have been able to, gotten the privilege to participate in the care process with her. She has two beautiful children, and it's just been a joy to participate with her in her journey. And I will let you take it from here, Danielle. But if you could help us describe your personal experience with this process and what were motivators, barriers to the process, what helped you, didn't help you as you traveled along your journey.
I mean, the one thing I really got to say is the kindness and compassion I was showed, because I had known prior that I was infected, and that wasn't always the case when I came into contact with doctors, and I was just welcomed, and it was just easy, and I felt, okay, I'm going to get treatment. I'm going to be taken care of. So that was just the best thing. And everything was streamlined in, I was already coming there for appointments, and it was just part of it, my Hep C treatment. So that was like the amazing thing with it. What was the other question you had asked me?
So what you're speaking to a little bit, Danielle, is the integration. So you were able to receive your treatment with your substance use treatment and with your prenatal care provider. So you essentially had one location where you were able to receive care for all of these different components of your care process. Am I articulating that correctly?
Yes, which made it so simple. It was so simple. It wasn't, because I think one factor is people trying to get treatment. You don't know where to begin. Okay, you got to go to a primary doctor, then they got to send you out to an infection specialist, and then so on, so on. So then I think it just gets, I don't even know where to start, you know? I think that's a huge challenge, but I came there and it was just all part of, you know, I'm already getting substance use treatment in my prenatal care. So it was so helpful.
And then can you describe a little bit for us kind of when you received the, like what was when you received the diagnosis and the who communicated that to you? How did that occur? Just that kind of initial understanding that this was happening?
So I had received it some years prior, before I became pregnant and started coming to McGee. I mean, the first initial thing, you just feel embarrassed. You know, I felt embarrassed, shameful, and it's nothing like, you know, you want to talk about even with a doctor, because it wasn't always the best of situations prior. And then I remember when I first met you, you were like so excited. I told my husband, I'm like, why is she so excited? It was because I was going to start the program, the treatment, you know, that you guys had for the Plusa. And I was like, what? But yeah, so I mean, I just felt, it was just like, just a shame feeling, you know, that you felt.
And how do you, and clearly the role of whoever you're interacting with, the provider or, you know, whoever, do you feel like that would be helpful to address those fears or those concerns, and that embarrassment that you may have helped, having somebody who was willing to listen and work through that with you? Clearly, would that have been helpful, you know?
Absolutely. Yeah. And just like, hey, we can get you treated, you know? I mean, because I had been clean for a long time, but it's still, you just have that, you know, feeling. So, but it was just so everybody was on the same page with me. I had you, and I had Hollis, which I don't know what her title would be, you know, for who worked with me, but I could get a hold of her anytime. She would text me, you know, as far as my treatment went. And it was just, it was so together for everything. I mean, just streamlined. So.
And then help me with, help me with how you felt about the need to get treatment, urgency for treatment. What helped you feel comfortable with moving forward with treatment, and how did the need for treatment kind of factor into everything else that was going on with you?
Well, you know, I was having my first child, and I wanted to not, you know, I didn't want to have Hep C anymore. And I felt I was just given such a great opportunity to be part of the Plusa trial and stuff. And so it was my son who I was like, no, you know, and also I didn't really know that there was treatment yet, because you had heard prior the treatments that he did have and interferon. And it was just, I had heard horror stories. So it wasn't even something I seeked in the past, because you heard those things. But then when I was presented with the opportunity to join for yours, and you know, the new medication that was out, I was like, okay, let's do this. So, and it was, you know, only one pill a day. It was so easy. But yeah, it was my son who prompted me to want to, you know, go further with this.
Because that's really important for, you know, that's great. And what any other, and you mentioned this in your discussion regarding apprehension or concerns regarding treatment, but us able to differentiate that the newer medicines that we have available have a much less side effect profile, and those the ease of the current treatment regimens helping you become more motivated for treatment. Am I phrasing that correctly?
Yeah, absolutely. Yeah. it wasn't scary, and everything was explained to me, you know, so clearly, and just like, this is what's, you know, it wasn't anything that's scary. It wasn't like with all these side effects or anything, because that was the biggest thing that I was scared of, because I had not known that, you know, that medication came out yet. So I had just known of the prior treatments.
Just to help everybody with frame of reference, you were treated around 2018, which was really when some of the direct acting antiretrovirals were coming to the scene. So that was really at that kind of critical point of transition.
Yes.
Danielle, is there anything that if you had a friend or knew somebody who had hepatitis, how would you speak with them about the need for treatment, or what would you tell that, you know, how would you communicate to them regarding their infection and what that may mean?
I mean, I'd like to tell them, you know, how easy the treatment is, you know, it's nothing to be afraid of, you know, go forth and do it. That I mean, that's the biggest thing, it's not nothing scary now. It's easy. The medication's easy. There's not these bad, you know, nothing to fear with side effects or anything. I mean, I remember I wrote medication diary for whenever I did it, and the most I would maybe get is a headache, but yeah, it's easy. It's quick. I mean, mine, I think, was 3 months, so it's not long, and then you're virus free, which is amazing. So
that's, you know, to kind of conclude on this, how do you feel now after treatment, and how different is that from pre-treatment?
I mean, I feel amazing. It's just to have that sense, you know, I no longer have, you know, Hep C, you know, when I've gotten tests and everything, my virus loads are, you know, gone and stuff. I mean, that is just the biggest relief. And just for me as a mother, just like, you know, that's not nothing that's on the back of my mind. You know, you might not have symptoms at first, but it's a slow killer, you know, and then later on. So my kids are going to need me later on, and I don't want to be, you know, so sick that I can't do things for them.
That's so wonderful, Danielle. And I just want to thank you so much for speaking with us and allowing us the privilege to know you and care for you, because it's really been a wonderful process. And you are, we really all look up to you for your bravery and your courage in this process. So thank you so much.
Thank you. Thank you for having me a part of this today and everything you've done for me in the past. I truly appreciate it.
Absolutely.
Thank you so much. Thank you so much, Danielle. It's so powerful, and I think I speak for everyone in that this is really a memorable part of this webinar. So thank you so much. Dr. Krantz, thank you for the excellent presentation and for allowing us the opportunity to sit in on that interview. And please take a look at the chat or the Q&A. I think there's some questions regarding this study as well. So with that, I'll introduce our next speaker. If we can play the slide deck. Our next speaker is Professor Saeed Hamid. Dr. Hamid is a world-renowned hepatologist, if I could say, and professor of medicine at Aga Khan University in Karachi, Pakistan. He was also the former chair of our technical advisory board for the coalition. Dr. Saeed, thank you so much for joining us, and over to you for your slide presentation.
Thank you very much, Neil, John, and Lindsay for this opportunity. And following on from the wonderful story that we've just heard, it really is inspiring, and I think it behoves all of us to do something in this area. So, Lindsay, am I sharing my presentation? Yeah, okay.
You're welcome to.
Right, I'm just doing that. This will move. Okay.
Great. And if you want to just put it in there, perfect.
Yeah.
Thank you so much.
Okay, so my task is to talk about patient preferences and attitudes towards linkage to care and treatment for hepatitis C in pregnancy. I don't have any conflicts of interest, and Danielle's story is a perfect segue into something that I want to also present as a real-life patient story, just to illustrate the difficulties around this area and things that we need to overcome. So this is a 24-year-old pregnant female who was referred to my clinic in 2012 from the OB service as she was found to be hepatitis C antibody positive. She's a primigravida in the 24th week of her pregnancy, feels well otherwise. Further testing shows a mildly elevated ALT. She's PCR positive. No evidence for cirrhosis on clinical lab and imaging parameters. And this is pretty much where her sort of cascade of care stopped at that point in time. She's advised the following. Her liver is functioning well, and she does not seem to have advanced liver disease. Therefore, we do not expect any problems during the pregnancy. Treatment for hepatitis C is contraindicated during pregnancy and breastfeeding, as of course it is even now the only exclusion in all guidelines, and particularly the WHO treat all guidelines. It still remains an exclusion. Of course, that was also the interferon era for us, and maybe doubly difficult to treat. She was advised that she can continue with the pregnancy, no special measures were required, and she can breastfeed, which she wanted to do. But then she was also asked to return to the clinic after finishing breastfeeding and get treated promptly for the hepatitis C infection. She returns in 2022, earlier this year, 10 years after the initial consultation. When I asked her why she did not return early, she mentioned the advice of no treatment during pregnancy. She got pregnant again very soon after she finished breastfeeding for 2 years, which usually what our women do in our country, and this end of breastfeeding was quickly followed by another pregnancy. Since then, she has now had 3 children, has completed her family, and therefore has promptly returned for treatment. Now we can certainly treat her, but the only caveat is that investigations now show that she probably most likely has advanced fibrosis and cirrhosis. And therefore, even if we treat her, we cure the virus infection, she still would be at some risk of developing sequelae from her hepatitis C infection throughout her life. So what we decided to do as a prelude to trying to develop a clinical trial in these women and lactating mothers was to just do a survey of the acceptability of HCV screening and DAAs in pregnancy. And this survey was done in 3 countries, Egypt, Pakistan, and Ukraine. It was led by the group, by Jeannie Collins' group in UCL, who did most of the work in developing the questionnaire and so on. And I'm grateful to Karen Scott for allowing me to use these slides that I'm going to show you in the next few minutes. The aim was to assess the acceptability of HCV screening and DAA treatment in pregnant and postpartum women in 3 high HCV burden countries, that is Egypt, Pakistan, and Ukraine. And we present here the socio-demographic characteristics, medical history, and knowledge of hepatitis C that these women had, the acceptability of universal HCV screening and DAAs in pregnancy, under the scenario, of course, that they were presumed to be, they were safe in pregnancy and had been approved for use during pregnancy. So this was a cross-sectional survey, random sampling, nothing, not a systematic sampling, nothing fancy. 630 women, 210 from each country. Ukraine was included as a potential site for women with co-infections with HIV virus. So there was one clinic that was HIV clinic that was included in Ukraine. In Pakistan, we included a major private hospital and a major public hospital with differing demographics, as I will show you in a minute. The inclusion criteria were age more than 18 years, they were pregnant or had delivered within the last 6 months, and had given informed consent for the survey questionnaires. The survey consisted of social demographics, pregnancy, and HCV history and knowledge about HCV in these women. The participants were given fact sheets about HCV and pregnancy. In Ukraine, these women read them by themselves and filled the questionnaire by themselves. In Egypt and Pakistan, they were helped in filling the questionnaire by trained field workers. Questions about acceptability of HCV screening and treatment in pregnancy and motivation for the use of DAAs in pregnancy, both for vertical transmission and also to reduce adverse pregnancy infant outcomes or for maternal HCV cure. And I'll show you the results now, which the demographics show that women in Egypt and Pakistan were younger in their age groups, a large majority under the age of 35. Some of these women had evidence of HCV infection in the past, either an antibody or a PCR test or both. In Egypt, about 3%, in Pakistan, 20%, and in Ukraine, 59%. The large majority had been negative for HCV infection, but a significant number had not been tested. For example, in Egypt, which has almost eliminated hepatitis C infection, 25% of these women had not been tested. About 10% in Pakistan had not been tested. We did not check it. Normally, women are not screened for HIV in Egypt or Pakistan, but about 40% of women that were included from Ukraine were HIV positive. Most of these women were currently pregnant. Some had given birth in the last 6 months. For some of them, this was the first pregnancy. This was a subsequent pregnancy and not the first pregnancy. There were a less level of education as expected in Egypt and Pakistan versus Ukraine. Most women had completed secondary school or college up to the college level, but not higher than that. So when asked about the awareness, have they heard of HCV infection? There was a very high level of the fact that people had heard of this infection. Egypt, 13%, Pakistan, 87%, Pakistan, 98%, Ukraine, 97%. So they have been faced with some sort of an infection within their families, HCV deaths and so on, within their families, within their neighbors, and so on. But when we asked them about HCV knowledge, there were significant gaps, questions testing knowledge of transmission, impact of HCV on health, vertical transmission rates, and possibility of treating pregnant women and children with DAs all scored less than 12 or less than 12, which was about 50% out of a maximum score of 24. When asked, do you think all women should be offered free testing for hepatitis C in pregnancy? There was obviously an overwhelming response to say that yes, women should be offered free testing for HCV in pregnancy, and they would happily get themselves tested if that was the case. When asked if shown to be safe, would you take DAAs during pregnancy? Again, a very reasonable response to say that yes, they would take the drug during pregnancy. What were the motivations? Mostly to stop vertical transmission. If this would help my child, I would take this medication no matter what. And to some extent, yes, to cure themselves as well of this infection so that they could look after the children better. The next question was, if shown to be safe, would you take DAAs during pregnancy? And this was broken down for women who were HCV positive or HCV negative. And there really wasn't any great difference in the responses. All of these women would very happily take DAAs during pregnancy for almost exactly the same reasons as discussed earlier. So to conclude, we found that there is a very high acceptability of HCV screening and DAA use in pregnancy overall. Similarly, high acceptability across participant characteristics, whatever they were. And there was 60% acceptability reported among non-pregnant women with chronic hepatitis C in USA by Kushner et al. So slightly lower, but still the majority would accept DAAs during pregnancy. The main motivation for taking DAAs was prevention of adverse pregnancy outcomes rather than maternal cure. But certainly maternal cure did feature in some of these answers. The large sample size, this was a large sample size and the first to focus on pregnant women in high HCV burden countries, and it included women from a range of socioeconomic and both HCV positive and HCV negative groups. The limitations were that the responses may have been colored by the scenario that these drugs were approved for use in pregnancy. However, the findings support the need for phase 2-3 clinical trials assessing safety of DAs in pregnancy to provide an evidence base to inform clinical and treatment guidelines. Thank you very much for your attention.
Thank you so much, Professor Saeed, for that really wonderful presentation and for expanding our conversation, globally in thinking about preferences amongst the population and communities that we serve. So please keep an eye on the chat, Dr. Saeed, in case there's any questions related to that specific study or your presentation. And with that, I'll pass over to Dr. John Ward to moderate our esteemed panel here. So thanks, and over to you, John.
Sure thing. Thanks, Neil. And thanks again to all the speakers for excellent presentations, and thanks to Danielle for her personal account of her experience, positive experience in receiving treatment for hepatitis treatment. That really goes a long way to demonstrate the positive impact knowledge, diagnosis, and treatment can have for pregnant women. We have a blue chip panel of clinicians with experience in hepatitis C care for pregnant women. So we really want to get them involved in the conversation immediately. So let me start off with Dr. Mona Prasad, who's representing the American College of Obstetrics and Gynecology. She is affiliated with the Ohio State Medical Center. She's in practice in Columbus. She's been active leading research for hepatitis C in pregnancy while at Ohio State and in collaboration with NIH. And Mona, I know you just probably have some perspectives coming from that that you might want to highlight particular aspects of what's already been presented or some particular gaps in that regard. But I also have been reading how with the new recommendation for hepatitis C testing for adults, the testing in pregnant women is increasing. A recent paper said about 40% of pregnant women were getting tested for hepatitis C. But yet we saw from Dr. Krantz study that there's still not a lot of treatment apparently being done. So I just wanted to see if you could start maybe commenting on what do obstetricians need at this point to feel fully comfortable and informed about routine testing for hepatitis C, and then what to do with that information for their patients.
Yeah, I'm grateful for the opportunity to share in this panel. I think this has been a really wonderful group and discussion. I think what we're experiencing right now is that we had pretty, new recommendations for universal screening in pregnancy, and we did not have the system of care, as Dr. Krantz has alluded to, that the system of care that's necessary to make sure that patients go from screening to cure just didn't exist. And then it seems like the burden of creating that system is falling on OBGYNs who might not be up to date really on what are the treatments, who is appropriate for treatment, how safe are the treatments, those kind of things. And so I think we have a group of providers that might not have followed this landscape very closely, some of whom might not really feel even comfortable with making the diagnosis yet. I think we have to start really rudimentary for this universal practice pattern to make sure people have all those tools and knowledge to help make those next steps. I think this is a great place where we could leverage our perinatal quality collaboratives to highlight where some focus could lie. I think this is a place where we could quickly educate a lot of people and create that cascader to help teach people what works in certain communities and what they could leverage in their own communities to create that cascade of care. And I do think, and I think the others can probably comment, I think we just are out in that stage too right now a recommendation not being quickly translated into uptake, and trying to make sure that people really are believing that that's the recommendation, and executing that in their practice. But I think having those downstream, anytime you do screening tests, you have to have that downstream next step, or people are not going to be enthused about screening for something that they don't have a next step for.
Thank
Those
you.
are my 2 cents.
Well, I think it's worth more than 2 cents. That's really very good remarks. And I think we'll be hearing from Jennifer Price in a moment, but it'd be interesting to see what type of collaborations between specialists and obstetricians would be helpful. But one follow-up question quickly, are there any programs ACOG is setting up to improve that knowledge base for obstetrics regarding obstetricians regarding hepatitis C care?
You know, I am actually unaware of that, but we can look into it. I know they've updated their practice bulletins and things like that, but in terms of more aggressive next steps, I am not aware that that exists, but I might not be the end user on that information.
Okay, we'll follow up on that. Thanks again. So quickly, let's turn over to Dr. Martina Bedell, who's representing the Society of Maternal and Fetal Medicine, who's an associate professor in the Department of Gynecology and Obstetrics at Emory University here in Atlanta. Martina, I'm sure you're seeing a variety of patients being referred to you, and just wanted to, sort of for you to share your experiences of managing those and among specialists within your society. Within different communities, do you see sort of the knowledge base of how to care for HCV fairly widely shared, or is it people sort of come to be known as the HCV care specialist, and then they get those referrals, within a community? I'm just curious about that capacity for care. Thank you.
Yeah. Thank you for the invitation to be here, including SMFM as part of this conversation. And I echo completely what Dr. Prasad said. I think, OBs are really, they are uptaking the screening as best they can, but I do think there's a lack of knowledge of sort of what to do with that. I'd say they often do then come to maternal fetal medicine specialists in pregnancy, but then we struggle with the lack of data on treatment in pregnancy. I think we're really familiar with using pregnancy as a window to future health, as an opportunity where people are in care that they weren't all otherwise, and it's intense care. It's a lot of visits. We are comfortable with diagnosing hypertension, diabetes, HIV, and initiating treatment for those in pregnancy for the benefit of the pregnant person, and then also for their fetus. And just like Danielle said, and they found in the study, I think pregnant people, it's a time of motivation for their health, not just for themselves, but also for their infant. And so, treatment for hepatitis C in pregnancy would benefit the dyad, both the pregnant person and their child. So I think sort of the key thing is just the lack of data. As we see with so many things, pregnant women are excluded from drug studies, vaccine studies, and that really, I think to move forward, we've got to get the data. I think so much of the lack of treatment is due to uncertainty, and not necessarily that we think it's harmful. It's just not having the data. And that at the moment, the postpartum linkage is such a challenge. Postpartum is a difficult time, for so many reasons, along with if you're breastfeeding it, just like in Dr. Hamid's case, like pregnancy, breastfeeding, pregnancy, all of a sudden you're years down the potential for treatment. So I think the way we see it is that really trying to work towards is there treatment that we can initiate in pregnancy, just knowing this is such a great opportunity that to make an impact on the pregnant person's health and potentially their infant.
Thank you.
Yeah.
One question, Ro, you touched on breastfeeding, and there's a question in the Q&A regarding what's the recommendation for taking HCV medications during breastfeeding. What's your opinion on that, please?
So I think right now the recommendation is that that's considered a contraindication, just like pregnancy. So we're currently not recommending that. But I think the other thing I wanted to highlight is I'm not sure how aware OBs and MFMs are about the case registry. I think we are familiar with registries for drugs in pregnancy, but I'm not sure that there's widespread knowledge of that registry, because I think, either doing the study in pregnancy or collecting enough data through registries is really important.
No, thank you
Mhm.
very much. Let's get Dr. Deborah Money involved in the conversation. She's a professor in the Division of Gynecologic Specialties in the Department of OBGYN at the University of British Columbia, and she'll be representing FIGO, the International Gynecology and Obstetrics Association. Deborah, it's so great to have you. And I mean, from your vantage point, and hearing from Dr. Hamid in Pakistan, what perspectives can you share just to highlight more some of the challenges for hepatitis C testing, linkage to care and treatment for pregnant women in low and middle income countries that we need to be mindful of?
Thank you for having me. Pleasure to be here. And, I think Dr. Hamid really did highlight many of the issues that face prenatal care providers in low and middle income countries where there's competing priorities, even just in the infectious diseases realm of ensuring HIV screening, other STI screening, malaria assessments and treatments, and general access to prenatal care with various levels of care infrastructure, depending on which country you're speaking of. So as usual, the highest burden of hepatitis C is in countries with lower access to care and costs for care being sometimes borne by the patient rather than by the system. So, low cost treatment and reflex testing is going to be a huge issue. We can't have always expensive laboratories. We may need to try to get more utilization of point of care PCR. We certainly need to enhance awareness of the importance of knowing about hepatitis C for prenatal care providers that are burdened with a million other important issues to deal with. And then if we could have an acceleration of studies looking at the safety of these drugs in pregnancy. Yet again, other speakers have referenced the slowness with which pregnant women are engaged in these kind of trials to provide us with the reassuring data we need. Most of us believe these in principle are drugs that are likely safe in pregnancy, but there may be one combination that is better than others. And then those drugs need to be provided at a really low cost for access to care in countries where they're having to prioritize all different other medications, vaccines, and so on. And so we really need to make sure those costs are brought down and simply access to the medications themselves. They have to actually be physically available in the countries and in the rural regions. So, I think I'm really echoing much of what other speakers have said, but I think it just gets amplified in low and middle income countries where all of these different issues of awareness and burdens on prenatal care providers with other things, perhaps lack of familiarity with hepatitis amongst midwives, amongst nurses, amongst primary care physicians who do maternity care. And certainly I think our OBGYN community internationally needs to get a little bit more comfortable and aware of hepatitis as a disease and hepatitis treatments over time.
Thank you so much. You raised a lot of the important issues for making this routine care in many countries around the world. As you probably know, there's a triple elimination movement that WHO and other organizations are championing to bring together the services needed to eliminate mother-to-child transmission of HIV, syphilis, and hepatitis B. Do you think as those get scaled up, it provides an opportunity to add hepatitis C to that triple elimination strategy?
I absolutely do. I think if we can bundle the cascade of care for all of these types of things so that we aren't sort of reinventing another stream of care for every disease, I think that would be hugely valuable. And for that sort of frontline care worker, if they could have a really easy flow of if HCV plus HIV, you do this. If it's Hep C, you do that. If it's syphilis, you do this. And not like I have to think about each one as another burden. So bundling, I think, would be fantastic. And, I think WHO would certainly be interested in that approach.
Yes, I agree. And the other takeaway from the survey that Saeed showed was just the universal interest of pregnant women to do things to protect their infant. And I think that's I think when you have that when you have the data to assess the burden and the value of testing, and then you have the knowledge to be able to communicate that through counseling, et cetera, to pregnant women, I think the acceptance of this intervention would be high with knowledge of safety. And
I completely agree.
Let's move over to Jennifer Price. Jennifer is a hepatologist at UCSF in San Francisco. She's the co-chair of the AASLD IDSA HCV treatment guideline committee. I'm sure you have a lot of perspectives to share from that vantage point, Jennifer, but I know right now it's a fairly neutral recommendation from those guidelines. You can just sort of verify that. But I will, and it emphasizes having conversations between the clinician and the pregnant women to make an informed choice about beginning treatment during pregnancy. And I just was curious if you have some direct experience or anecdotal experience of what type of counseling should be done, what when in pregnancy should that be done, and what are some sort of key takeaway messages to guide that counseling happening between clinicians and their patients. Thank you.
Yeah, I would say, the neutral recommendation is with regards to treatment. It's because of the, what everybody's already mentioned, the lack of safety data in pregnant people and in breastfeeding. We just don't have enough evidence to recommend treatment during pregnancy or breastfeeding, but we do believe that it can be considered on a case-by-case basis. And I think, discussing the potential risk, versus the benefits of treatment, allowing pregnant people to make their own decision about it. I personally have done this on a very small case-by-case basis, but I think even just having the conversations during pregnancy, even if treatment is not started, it starts the process, and we've already established the relationships with the patient that we can follow them after a delivery. We have other models like Dr. Krantz explained, where people get referred after they've delivered, and I think that those don't work as well because so much is happening in the postpartum period that they just don't end up in our clinic. So one of the challenges, for our society, AASLD and IDSA, is really getting people, to the clinic. We really rely on the frontline providers to be doing the heavy lifting in terms of the screening and the referrals. And I think we need to become more engaged in that process. And listening to what people are saying, like Dr. Prasad, it reminds me a lot of what we went through, a decade ago when we started implementing the birth cohort screening in 2012. And, I think we could take a lot of the lessons that we learned during that experience and adapt it and apply it in this population as well. Provide more education to frontline providers, potentially in the form of, echo clinics, but also just other didactics, and really improve the lines of communication and open referral pathways. And there's a lot of models that have worked really well outside of pregnancy, where we integrate care and really bring the hepatitis C treatment conversations directly to patients instead of making them, come and find us in the clinic. So I think there's a lot of really exciting opportunities, but the biggest limitation we have in terms of treatment is, of course, what we've already heard, and the lack of the data.
Yeah, thank you. I was there when the DAAs came about, the all oral DAAs, when this IDSA AASLD committee was formed. And do you think there could be some potential value of an AASLD, ACOG, or fetal society of fetal maternal medicine, et cetera, coming together and just beginning to lay out, what is known, what are the research priorities, and sort of help this knowledge get elevated among obstetricians? What do you think about that idea?
I think that that's a great idea. I mean, the ASLD IDSA collaboration has been just tremendous. And I think we benefit from the expertise of each society. And the guidelines have been accessed by, millions of people. So I think that that could be a really fruitful collaboration.
Yeah, I mean, that low percentage receiving treatment is, it's a real call to action. And Saeed's case study is just examples of what's the adverse consequences when that treatment doesn't happen, when that patient's in front of a provider. Our last panelist is Dr. Megan Baresh, representing the American Society of Addiction Medicine. She's assistant professor of medicine in the Division of Addiction Medicine at Johns Hopkins School of Medicine, with a joint appointment in the School of Public Health there. As was evident in the presentations, at least particularly in the United States, pregnant women with HCV have issues with substance abuse disorders. Just wanted to give you an opportunity to highlight some of those challenges in for pregnant women with those disorders, and then how do you best bring in and introduce hepatitis C testing and considerations for treatment for those women.
Sure, thanks for having me. So I think that really what's already been highlighted, I think the two big issues are the segregation of care. So we already see segregation of addiction treatment from other medical treatment. There's promising work happening with bringing Hep C treatment to opioid treatment programs or methadone clinics, which is a US specific model. We know, we have evidence that among persons who use drugs, including active use, that Hep C treatment is effective. Need more kind of in the population of pregnant people, but I think we can apply that. And we also know that integrating into primary care. So I personally do, and there's a lot of buprenorphine treatment in primary care. And I should say globally, a lot of places there's variation access, but less restrictions to OUD treatment. So already methadone in primary care in the UK, Western Europe, and Canada, and pharmacy dispensing. And I think we can be using our pharmacy colleagues more. So I think to and then I personally have been uncomfortable treating, as I do primary care as well as addiction specialty, and I see many women of reproductive age, and personally had someone who we were ready to treat and had an unplanned pregnancy, and then we delayed because of lack of data. She fortunately, I think it's an example of the success of continuity of care, because I've continued to be her PCP and bupe provider and do her Hep C treatment. She just finished treatment and is doing really great. But when it's kind of siloed and segregated cares, especially if you're waiting till postpartum, it's really tough. So I think we'd personally be really excited to see more data to treat during pregnancy. And then just, I think, more work of bringing the specialty treatment to where people are already presenting, including cost barriers to acute care settings. Persons who use drugs present very frequently to the hospital, to the ED, and we're doing better jobs of testing and screening. But then I have to say, you have to wait and follow up because it's not covered in the US at least. You need to wait and get prior authorization as an outpatient. And I think also the insurance barriers they're still requiring, apart from the guidelines, chronicity of infection. So kind of evidence of 6 months. And so even for patients with cirrhosis, and it can be quite a battle. So thinking about when are people presenting, because when you can cure people in 8 weeks of treatment, if you can co-locate that care earlier, then we could be treating and curing a lot more people.
Thank you. Thank you for also raising that there are other issues, for all HCV infected patients that come into play here, like those prior authorization and other requirements to get the prescription reimbursed. Thank you for that. Quickly, there was one, just to get everybody involved, there was a question, a comment in the Q&A that pregnant women, you'll see, please fill out the evaluation while we have this last 5 minutes of the webinar. A comment was made that in Africa, pregnant women are particularly reluctant to take medications during pregnancy, except for HIV during their pregnancy course. Just want to get people's viewpoint on that. Is that, obviously we all need safety data, but do you think that will be a major hurdle as our registry collects more cases, and we have some safety data to bring to the table. Any thoughts?
Well, I'm happy to jump in. I mean, I
Please.
think, I think my limited experience in working with my colleagues in Africa is that, in many cases, their approach to drugs in pregnancy are not really all that different. They're individuals who are concerned about safety and concerned about the health of their baby. And if they don't, maybe don't have full trust in the health system at times, they want to know that whatever's being recommended is going to be safe and is not part of an experiment. There's a little bit of that. But, we've just been working quite closely in Rwanda with the University of Rwanda and the Department of OBGYN there. And the women coming into care there are willing to certainly take treatment for malaria if appropriate. They're willing to take treatment for syphilis when appropriate. And for the most part, HIV for, there's affordability barriers and so on. Tuberculosis treatment is not uncommon. So I think, with the right presentation and the right care providers who are trusted that are presenting information on DAs and for Hep C, I don't think that in and of itself is going to be the biggest barrier. I think it's all of the other things we've been talking about.
Thank you.
That's my perspective.
No, thank you. I did have one other question for Dr. Collins, if she is still on, yeah, there she is. I was also struck by the sort of adverse outcomes of the pregnancy itself and for the infant, and it seemed like those don't get highlighted enough, that there's already some reasons to optimize in the pregnancy outcomes to clear that infection for the pregnant woman. Do you agree with that, and do you think we can do a better job of strengthening that aspect of the evidence base?
Yeah, thank you. I agree when we were, so just to say our colleagues are working on planning for a trial to look at a phase 3 trial looking at safety and efficacy of treatment during pregnancy and breastfeeding that will be presented at the next session. We were also quite surprised when we reviewed the literature to see the evidence on the potential adverse effects of hepatitis C during pregnancy. And one of our hypotheses would be, if you did treat the mother during pregnancy, reduce the viral load, could there be an impact? We don't know yet on reducing some of those adverse outcomes. And that would be one of the key outcomes of interest in a future trial, if that, in addition to reducing vertical transmission. I think one thing we have to note that most of those large data has come from high-income countries, I think the USA and Sweden, where there's very specific characteristics of the women with hepatitis C. We do certainly need more data from other settings, but similar findings have been observed in other countries such as Egypt, showing quite severe adverse outcomes, but based on much smaller data sets. But I think that there does seem to be increasing evidence to suggest that.
Thank you. Unfortunately, we've come to the end of our 90 minutes. It's been a very informative, very, really, frankly, exhilarating presentation and set of panel discussions. I greatly thank you all for that. Thanks to Dr. Collins for giving a teaser for the information or issues we'll be exploring in more detail in our upcoming webinars. I'll now turn it over to Neil to have some closing comments and to close the program. Neil?
Thank you so much. I think it's clear that we have a call to action here. I think the challenges have been laid out brilliantly from many different sectors. I think we have the right people at the table. We'll continue to expand this community of practice, particularly in globally, to ensure that we have proper representation and engagement from highly affected regions of the world. And in our next sessions, which I hope you will all join, and we'll reach out to you shortly to do so, will be January 25th, where we'll really get into the meat of the issue and talk about operational approaches that people have used to improve linkage to care. So we'll hear from experiences around North America and globally in actual programs that have been implemented. And then in March, we'll even take a more forward look at these clinical trials and registry efforts that have been put into place to provide the data that you've all highlighted is in dire need to inform decision-making for both providers and patients. So thank you again to all the panelists, all the speakers. Thank you to the audience and participants. Please reach out if you have any questions or suggestions for the webinar series. And please do submit cases to the registry as well. Thanks again. We'll put all the materials on the website, and thanks for joining. We'll see you at the next section. Thanks all.
Thank
Thank you
you.
again. Thank you.
Bye-bye.
Thank you.
Thank you.
Thank
Thank you all.
you.
Thank you.
Bye-bye.
Well done. Thank you so much.